Okay, good morning, everyone. Welcome to the Department of Psychiatry Grand Rounds. Really excited to introduce Dr. Leslie Hulvershorn, who is going to be giving us a presentation today. I'm just going to say a few words about Leslie, who's a dear friend. And Leslie is the the department chair. She's a professor and chair of the department at the Indiana University Medical School. And most of her medical school training was there, including undergraduate, actually, although she graduated early from undergrad at Indiana University. So she spent a fourth year at Oxford University. And then she did her medical school and residency at Indiana University, then went to NYU for her child fellowship, and then has been on faculty at Indiana University, has been studying adolescent substance use disorders, neuroimaging. That was kind of one of the areas that we've connected. We've published a few papers together, and has been really involved in many different aspects of mental health care in the state of Indiana, and has really been developing a lot of cool ideas and programs. So I'm super excited to hear about her work. Please welcome Dr. Hulvershorn. I'll go around this.
It's here to switch the slides by sitting down, so I'll just do that. Okay, well, thank you so much, Katie. That was really sweet. I'm really excited to be here and see you and other folks that I've known for a long time. And I've never been to Minneapolis, so I'm from one of the Appalases, right, Indianapolis. But I really like this Appalus with all of your lakes and trails, and it's very beautiful. So thanks for having me. And this building's incredible. What a cool thing to have dedicated to developing brains. So really pleased to be here. So I think what I'm gonna, I do imaging work, but I'm really gonna focus today on developing like what we've done and what we think are best practices for developing adolescent addiction treatment programs and care. So that's the focus for today. I don't think I have any actual conflicts here financially. Unfortunately, I don't really have any smart investments in anything that would be a conflict, but I do have funding, so I just shared that. So hopefully by the end, people who are here will know a little bit more about phenomenology and treatment best practices and some of the, strategies you can use to develop infrastructure given all of the funding and constraints for caring for this very vulnerable population. So we'll talk about the evidence-supported modalities, the arrays of care that are needed, and then some things that we've tried to do in Indiana to make it work for a state with not a lot of resources, a lot of rural areas. And so here we go. Apologies if you've heard me speak. I like some of the same pictures over and over again, but so it's really easy to make the case that substance use disorders are an incredibly huge societal problem. If we think about, driving under the influence, the developmental derailment that happens with kids who use substances, it can really change the trajectory of their lives. There's entire textbooks dedicated to the medical consequences, not only, thinking about the psychological side of things, but the medical consequences alone are enormous. And then just the cost related to incarceration, kids in state care because their parents are substance involved, homelessness. I mean, it just spirals. And this number is actually really an old and out of date number. So it's almost harder to imagine anything that's more expensive, frankly, than substance use disorders. If you look at the impact. And there are the number one reason why children are neglected or maltreated is parental substance use. So that's just my little reminder. Every hour a baby's born, suffering from opioid withdrawal. That's actually out of date too. It's probably more than that. But anyway, the consequences are very dire, and those of us that work in child psychiatry know this. We see this every day. So it's a hugely important area, and I think the beauty of working with adolescents is we really try to get in there before things get out of control, right? So this is an image from the Faces of Meth project. So this is an interesting project where publicly available mugshot images are curated to just show the effect of substance use on people's faces. So, when you get arrested, you get a mugshot, right? So this is a woman who was arrested multiple times. She was using methamphetamine. And she died shortly after, the year after that last picture was taken. But you can just see the effects of, I think at age 28, she looks older than a 28-year-old. Like, it already was taking its toll then. And she just becomes, cachectic and probably very impaired, and just continues to get arrested throughout that period. So, it's a really hard thing to get under control in adults by the time it's already spiraled to be this level, right? So the effect size for treatments for severe substance use disorders in adults are not what we'd like them to be, right? They're low. And so the whole point of this talk is, what if we instead intervened when she was, say, 12 and she started maybe using nicotine, or 13, she was dabbling with alcohol or cannabis? Like, what if that's our strategy instead of first seeing her in the treatment, setting, when she's in her 20s. So that's I think hopefully illustrates why we want to do this early. So just a reminder for those of you who don't live in this space, all of the reasons why we worry about substance use in young people. One of them is that the suicide rate tracks closely, right? Suicide is highly related with substance use, right? A lot of people who die by suicide, and I don't know the exact percentage, but I remember it being very high, do it while they're under the influence of a substance. And so, epidemiologists will always want to covary for substance use when they're looking at suicide rates, right? They're highly related. So this little factoid is, adolescents who use alcohol in the past year were more than twice as likely compared to youth who didn't use alcohol to attempt suicide. So highly correlated. And then we know that there's, of course, a bi-directional, very complex relationship with mood disorders, psychotic disorders, I think the general public does not, especially the cannabis psychosis story, really understand that well at all. And for those of us, again, preaching to the choir here, working with children with psychosis, it's an enormous issue, right? And actually, what's the deal with cannabis in Minnesota? Like, legal, right? But for medicinal and recreational. So you probably see a lot of it. We see a lot of it also in a state where it's not legal at all in any capacity. But this is a period of time right now where the public perceives that cannabis is safe and healthy and in fact good for you, right? It's natural. And so, those of us interested in mental illness are finding lots of concern with that, right? And the narrative in the psychosis literature for a long time was, well, if you have this genetic predisposition, right, then cannabis is a problem. And now it seems to be shifting more to, you can have virtually no, genetic predisposition, but the potency of the cannabis is so strong that the risk of developing, lifelong permanent psychosis is actually shockingly high, especially among those that have transient psychosis when they first start using. So it's a huge public health problem that the public is not really aware of, I think, in many ways. And then, of course, the third point there is just that the people think of adolescents as, how bad could it be when they're using substances, right? It's like, well, if you think if their job is to go to school, their job is to, track through development, this causes tremendous impairment, actually. And so it's very easy for them to make. Yet fewer than 8% actually ever engage in any treatment. And it depends on where you are, but like in my state, it's lower than that. But it's, I just always think, imagine if that was cancer or something, like how appalled we would all be if fewer than 8% of kids with cancer got treatment. But it is not appalling, I think, societally, right? Because there's so much stigma surrounding these disorders that, in fact, many, most people don't get treatment. And most people's idea of treatment is very different than what good treatment should look like, right? So, and then, you guys are a lot of brain imagers here. And so this is actually one of my favorite Susan Tappert stories. So she's an imager in San Diego and especially interested in substance use and risk for substance use. And she tells a story. This is just my reminder to talk about this story. So with her postdocs and students said, hey, what if we took a group of kids who only had a couple of episodes of binge drinking and compared them to healthy kids who've never had any binge drinking. She was like, don't waste your time. A couple of episodes of binge drinking will not do much, right? Well, the students went ahead and did the analysis and good for them, right? And they did some white matter analyses and actually found some, white matter microstructural changes associated with a very small number of episodes of binge drinking in adolescents. And these are not kids with alcohol use disorders at all. So I think the idea is that alcohol and substances, we're just beginning to understand their impact. We only now have these longitudinal studies and methods to allow us to understand that the impact is actually probably greater than we would have, any of us would have thought when we were growing up, for example. And then the age 14 keeps coming up in the imaging literature as just a pivotal time, whether you're talking about cannabis or alcohol, that has, the effects on the brain are quite drastic below the age of 14. They're not great for 16, 17, 18, you're right. I mean, I'm not advocating heavy use then, but something about age 14 and just a number of studies seems to indicate that, boy, is it a pretty hazardous thing to do at that age in terms of brain function. And so there's animal literature and this factoid that not only are whatever's happening in the brain seems to really increase one's risk for substance problems, especially with early exposure, right? So childhood exposure to substances, the fact here is, 47% became dependent later on compared to only 9% who began drinking at age 21. So a really good message to patients is, waiting, right? Because that sounds better than never ever, right? You're not a teetotaler here, but, waiting, the longer you can wait, the better for your brain, the better for your development. I work a lot so something I've been doing lately in the last couple of years is engaging more with primary care physicians around caring for patients. And one thing I find there that's very interesting is you have to kind of convince people that this matters and that this is something they should engage with, because it's not intuitive actually that it's really bad for people to use be vaping and using substances. So just a basic point here, but if you're using early, this is not a good prognosis, right? The adolescent brain is more sensitive to the toxicity of substances, and it's a really crucial period. So it's like the worst time ever to use substances. Like, I'm 48, so maybe that actually probably wouldn't be the worst time. There's not that much dramatic changing in my life, right? At age 48, if you could choose, right? I'm joking, but like 13 to 17 is like the worst time you could pick, right? In terms of all the things you got to get through in your brain development, but that is when many adolescents actually start using. So. And again, clinical group, this is probably not news to you, but prescription or drug-seeking behavior is a concern. And there's all kinds of research that shows if kids have access to peers who are using substances, even if the caregivers will say, oh no, my kid doesn't use, like odds are they are using, right? And unsupervised time, really good research from many, many different groups showing that's, if anything, if there's one thing that predicts adolescent substance use, it's unsupervised time. So pro-social activities, knowing where your kid is, parental monitoring is a big part of treatment. And then you'll find these people, and I'm sure you see them in adult settings too, where it's probably their insula is like tuned up to a little different or something, but they feel uncomfortable, right? And they need to medicate everything. And of course, if you're dabbling and trying lots of things and unable to tolerate any kind of discomfort, you're gonna potentially end up being a person who's more likely to develop substance problems. And this is obvious, but if you're using substances, you probably have a substance, more likely, you have a substance problem. So I say that because I get from pulmonologists, I get from primary care docs, well, you really want us to refer people for treatment because they're vaping nicotine? Yes, that is a substance use disorder. We can treat that, and it has huge consequences, right? So yes, if people are using heavily and having consequences, we should treat them. And I get the same thing, like, you really even care about cannabis? Yeah, we should treat cannabis use disorders too. We should assertively go after them and try to get people to stop using, because we have treatments that work for so many reasons. It's a good idea. And then, of course, highly genetic collection of disorders, right? So that's a risk factor. And how is substance use different in adolescents than adults? Of course, less chronic, less refractory, haven't been using as long. Withdrawal is not a big part of what we do unless we're talking about opioids. I mean, I've seen benzodiazepine, sedative hypnotic withdrawal a few times, but alcohol withdrawal is just something that seems to take a long time to develop. And so you very rarely see it, which makes it a little bit easier to care for adolescents. And you can often avoid inpatient care because you can safely manage these things outpatient more often. But they can be very severely affected. And sadly, there are fewer resources, way fewer resources. I don't know if you find that in this state, but I think it's true in almost every state. But the good news is, and one of the things I like about it is you have a lot more levers, you have a lot more oversight, you have probation officers, child welfare, parents, caregivers, to help. So our treatment models include those, and it's very different than adult treatment models. And then kids tend to not have the resources transportation wise, although this is sort of no longer true. So I had a med student do a project on this, and I learned this that way. Most people young people who die from an overdose nowadays purchase their drugs off of Snapchat. So it used to, if you could physically constrain a kid, keep them in their house, they'll be safe, right? now, you know, they just order on a Snapchat, pop out the door for a minute, Mom, I'm just getting a paper, or I'm just gonna go grab a Coke, you know, and then they've been able to procure fentanyl or something. So it's a much more dangerous landscape now, and access to substances is very different. And fentanyl is a huge, huge problem, and it has really spiked mortality of substances. And interestingly, way fewer kids use drugs now than in any other decade that since we've been measuring. So 60s, 70s, 80s, 90s, young people used a lot of drugs, right? Now, way fewer of the population is engaging in any substance use, but those who are using much more lethal substances. So the mortality rate has gone up a lot, even though luckily way fewer kids. A lot of kids have said no thanks on alcohol, no thanks on a lot of substances, but there's more deaths happening. Okay. And so it's pretty, it's pretty common to use drugs. And again, less common now than in prior decades. And so, 5 to 8% of adolescents are meeting criteria in the DSM for substance use disorder. So it's not rare, but it's not everybody. There used to be there is this concept called gateway drugs, and it used to be this thought that there are specific substances that if we if you use these, it's going to lead to something more severe. And that is true, but it turns out it's whatever you have access to is your gateway drug. So it might be that cocaine is easy to find, or in this case now fentanyl is easy to find. So we see 13-year-olds who've never used a drug in their life, and they order fentanyl because they don't know what it is, and it's a pretty color pill, it's rainbow. And so they're like, we'll use that. And so, the concept of that it's got to be alcohol or tobacco or marijuana, the gateways, is not accurate. So our big problems, we kind of touched on some of these. Cannabis, this perception in the public that cannabis is not dangerous, that it's safe. And so anytime there's a perception that a drug is safe, that means the use is going to be much higher, right? That's well documented. Vaping is a big, big deal for kids. And not just the actual use of the vape, but the consequences of the vape. So schools are really cracking down. So if I had $1 for every patient of mine that was expelled because they vaped at school, I would have a lot of dollars. And it really is not helpful to expel kids, right, developmentally. And so this enormous situation of the schools are trying to handle it, parents are trying to handle it. I mean, we even have a county in Indiana, and they actually got written up in the New York Times because they're so unique, where they're getting arrested, because for vaping and like incarcerated. So, I mean, adults are freaking out about vaping. They don't know what to do about it. And the consequences are not always really very helpful. Fentanyl, of course, so manufactured by drug cartels and trafficked into the United States. So in Indiana, our drug trafficking route, from what I've learned from our DEA agents, is Chicago is a main distribution point, and then comes down I-65. So we have a pretty good access to fentanyl. I'm guessing that would be maybe a similar pathway here, directly into Minneapolis. I don't know. And I don't know if you guys see vaping fentanyl as a big issue. In Indiana, we have the 4th highest death rate among adolescents in the nation. So it's a big problem. And it's very much depends on where the cartels have been able to penetrate in certain markets. It is present now in almost every substance. So we see patients regularly who are using cannabis, and they will test positive for fentanyl. And it's so many of them, I believe them. They're not intending to use fentanyl, but it's processed around it. And of course, there's deaths. You read about tragedies where kids are sleeping in a bed where there's traces of fentanyl from a parent's use, and they die, right? It's just an incredibly potent opioid that, decreases respiration and people die. And methamphetamine is a big issue as well. I don't know if you guys experienced this here. Less so in youth and more in adults. We're actually part of a multi-site trial with NIDA, and it's like the easiest trial to recruit that we've ever done. And I wasn't expecting that. I was like, wow, we really have a lot of methamphetamine use, I guess. But in like clubbing land, men having sex with men, like accentuating the experience with methamphetamine. So those are kind of the current issues in many parts of the nation. And risk factors, not a whole lot new here. This is something that people have studied for a long time, but it's important to remember that it's so multifaceted, right? So we have this, what's going on in the nation? What are the drug cartels doing? What's the DEA doing? How effective are they? So there has been a big we were beside ourselves with the number of our patients who were dying, like in the hospital. We had a patient die in the hospital who got, it was like, I've never seen interns like sob so loudly in our hospital. Like the DEA really was having a hard time constraining the fentanyl supply in 2021 and 22, and it's gotten better. So there's all these articles nationally about there was a big crackdown, and so there is less fentanyl available. So overdose deaths have increased. I mean, it's better this year than a couple of years ago, but it's still an issue. So things like that can dramatically affect access. And of course, if the more lethal the drug, a death is a very different outcome than, someone who's just trying to smoke weed and they didn't expect to die. So that's a big thing. And of course, we talked about it at the individual level, familial level, genetics, all the activities that surround a young person that can be protective, right? So 4-H is like one of the most empirically supported drug prevention interventions, right? So just having the structure of something else to do, athletics, it depends on the sport. Again, my med students teach me so much. Certain sports are protective, certain aren't, depending on the conflicts. Like hockey, I think, was a concern. Soccer was good. I was relieved to see soccer. Swimming is sort of depends on the group. But sometimes you get access to kids who are using drugs, which is bad news. Other times you get access to kids who are not using drugs and who are, good supporters, and you can distract someone from substance use. So it just really depends on the microenvironment. So it's very complicated. And then, he's suddenly, like with my own patient, suddenly Uncle Bob's here and he's a weed smoker and has got access to all these drugs, moves in, sleeps on the couch, things fall apart, for a family. And so it's really very much dependent on supply and access. So with my imaging work, I've been very interested in predicting substance problems. And so we talked about early use is a huge issue, right? So don't let 10-year-olds, we've had 9 and 10-year-old patients in drug treatment programs, right? I mean, you see this, especially folks who are like maybe the parents involved in distribution of methamphetamine, the kid gets into that and then is also using other substances. So those kinds of environments, very, very concerning. And then of course, 80% of the variance is explained with substance use from genetics, highly genetic. People forget that, I think, sometimes. There's in the public, there's a big narrative. If you're exposed to trauma, that's what leads to substance use. And it's certainly part of the story, but highly genetic. And then if you look at kids, there's been a lot of really good longitudinal studies, including some from here, where especially in boys, this childhood phenotype with externalizing disorders, the ADHD, ODD, conduct disorder phenotype very robustly predicts substance use. It gets a little more complicated when you add females into the story and then mood disorders, right? Because I have their onset a little bit later, and that's people have hypothesized a separate trajectory. Females have been underrepresented in a lot of those samples. So, and then the environmental moderators we already talked about, right? The peer group has an enormous amount to do with the childhood stressors, trauma, all of that certainly plays in, availability of drugs, antisocial activities. Ralph Tarter's one of my favorite authors in this area. He's been at Pittsburgh. I think he retired now, but he's a neuropsychologist, and he termed the coin neurobehavioral inhibition to describe this constellation of familial substance, lack of parental monitoring, externalizing disorders. That's the perfect storm for, at least in males, developing substance use problems. And of course, if you're working with folks with substance use disorders, they almost always have mental health conditions, right? This dual diagnosis concept. And so you'll see nonstop externalizing disorders, and tons of, depressive disorders, mood disorders. Just because psychotic disorders are relatively less common in the population at these ages, you'll still see them, but less often. And unfortunately, the treatment models don't work as well with folks with psychotic disorders, right? 'Cause it's a lot of cognitive models, and that can be really hard for someone who's, really actively psychotic. And then plenty of PTSD, right? So we actually in our program kind of almost joke, like I think we've seen maybe 3 kids over 15 years that we think didn't have a psychiatric comorbidity out of, I don't know, thousands. Like, oh my gosh, they don't have, it's like basically we assume you're going to have 5 or more psychiatric disorders if you also have a substance use disorder. So, so comorbidity is the rule for sure. Okay, so what are the clinical approaches that are helpful? And there's been a lot written about this. So the SBIRT model you've probably all heard of. It's an interesting model, and here I'll just switch to this slide. It kind of lays it out. So screening, brief intervention, and referral to treatment. This has been a big focus of funding over the last, 20 years. And the idea is that in primary care and emergency departments, everyone should be asking these questions. The problem is where SBIRT breaks down is actually getting people to treatment. The rates are really, it's very low. It's very ineffective. So we are in our state, the state funded a lot of SBIRT programs, and our director used to joke that he could stand on a street corner and yell, "Does anyone need addiction treatment?" and get more people into an addiction program than funding a $2 million SBIRT program. And I have to say that's been my experience as well. So, I mean, it's a gap in the literature in the field. How do you get people to want to engage in treatment? Who, I mean, there's all psychotherapy is dedicated to this, but it's a real problem. So we're pretty good as a nation and world at asking about it, maybe doing some brief intervention around, oh, good, you're not using, that's great. Okay, you've used once, let's talk about that. But then, oh, you do have a problem, let's get you into treatment. That's where the model falls apart, and we really don't, as if, know what to do with that. So NIDA will tell you that. SAMHSA that continues to fund SBIRT programs, and they won't tell you that. But in general, the idea is we should be asking. And of course, our goal is just who may have problems, and if so, we need further evaluation. Screening is not diagnostic. That seems really rudimentary, but I can't tell you how many states develop programs that only have screeners and no assessment as part of it, right? That's a very common mishap. So there's a whole bunch of different screeners that are useful. I actually recently got kind of scolded by someone from NIDA for talking about the craft as a screener. I guess they don't like that as a screener anymore, some new data. So we use the BSTAT and the S2BI are probably the most, commonly used. So we have the BSTAT in our EMR, and S2BI is also a good one. The idea is there's some follow-up questions that you can harness, but and these are like 30 seconds, 60 seconds, like for, really, really quick screeners. So the hope is, and the recommendation from the American Academy of Pediatrics is that every pediatrician is asking these questions. If they're in their emergency department, they're getting asked. Of course, psychiatrists, we're asking them too. In reality, that does not happen very often. This slide looks kind of weird, but my issue in like the chair role and the state work that I've done is it's not hard to screen. We can all screen, but then what about that assessment? That's a real problem, finding clinicians who are skilled at assessing for substance use disorders in either adults or adolescents that can do that in and you can patients can actually get in, their Medicaid, and get seen in a timely fashion. Like that's a huge bottleneck. It's a missing piece in the system. And so I heard Robert Gibbons speak once and became very interested in the work he's been doing. So Robert is a statistician. He's not a psychiatrist, and he works at the University of Chicago. And he was appalled when he learned that psychiatrists take like 2 hours to assess people. He thought with his statistical brain, there's no way that's necessary, that you actually spend 2 hours to conclude that someone has, major depression or whatever. And so he's worked with a lot of top psychiatry departments. He worked with David Brent on the KCAT. He's worked with a lot of other folks at NIH-funded studies to develop this suite of tools that have come to market and I have no commercial interest. I have assisted, but I intentionally do not receive payments because I did not want to have to disclose whatever if I got $600 or something. So I have no financial interest here. So they have developed a suite of adaptive tests. And the whole point here is they use multidimensional item response theory, not AI. And what that allows you to do is you can basically, instead of asking 50 questions, they use the IRT to determine that asking 2 questions gets you the same result. So he says you don't need to ask all the DSM criteria to figure out if someone has depression. We can empirically demonstrate that you can actually just ask 2 questions. For example, if someone's had 6 DUIs from alcohol, don't ask anything else. They have an alcohol use disorder, and like he will demonstrate that with different samples. So that's the idea behind it. So he says, I bet I could take a 2-hour mental health assessment and break it and get it down to 4 minutes, right? If we ask the right questions. And so so he has validated this. And so he compares, like in youth, the KSADs to the KCAT, and finds, oh, look at the area under the curve. It's nearly identical. Like these are reliable ways to determine this. Now, this is sort of a hard pill for a lot of people to swallow, that you could do a mental health assessment with self-report and get it done in 4 minutes. However, so I'm not saying it should replace all mental health assessments, but when you look at the public health landscape around the nation, that we are so far from meeting the need for high quality assessments that doing this alone would be way better, in my opinion, than what we're doing now. And so we've started to utilize a lot of these tools across our system. And one of the things we observed early on was that I did not like substance use assessment. Everything else was great for mental health. It was really specific and, with the exception of autism, the 2013 or whatever, the old case outs did not have an autism module, and he developed it off the case outs. So that's why I think they've added it. They've subsequently added PTSD as well. But anyway, but the substance things were just like, do you have a substance use disorder in your life? Like, that's not helpful. We don't need to know that, right? We need to know, do you have a current opioid use disorder? Do you have a past alcohol use disorder? Like, that's the level of specificity we need for treatment. So our team at IU worked with Robert, and we collected a whole bunch of data from adults and youth. And so there's a different version now of the CAT is the adult version and the KCAT is the youth version. And so there's also now added onto the mental health component, a more specific substance use disorder version. And so this is just showing some data from the adult version, but Zach Adams is the first author on the pediatric version. And so if it's 4 minutes for mental health and maybe another couple of minutes for substance use disorders, you can get at a pretty comprehensive assessment of a patient's status. And this is a self-report, computer-based thing that can be sent to their phone. So what we're doing in primary care is sending it to the parent and child's phone in advance of the well child visit or a new patient visit. And when we started off, they thought it was like a hacker or something because the text wasn't very clear. And so no one responded, but worked through that. Now, most of the time without any intervention or help, we get about 25% of those visits reporting. If we work really hard at it, we can get up to 50% in some of the practices. So it gives us a lot more information, and because it's an adaptive test, meaning if you say, yes, I had a DUI, then we're gonna ask you something different than if you said, no, I don't have a DUI, right? So it changes like the SAT. You can repeatedly administer it, and so you can monitor progress with treatment really easily with it. So we've got it embedded into our EMR. It's approximately $5 per patient per year. So, and there are ways to get reimbursed. We're still trying to figure that out, but it's not free. But the psychometric properties of this substance assessment far exceed any other on the market. So it's helpful, and I think it's something to consider when you're thinking of, okay, we screened, now what do we do with all these people? We're just not even screening, like, let's just do the 4-minute thing. Although we sometimes battle with the pediatricians on that. Okay. So that's assessment. And so in general, sometimes it gets confusing around substance use. What is good, safe advice? I mean, you can always say, this is not motivational interviewing, by the way, which we'll talk about in a second. This is the opposite of motivational interviewing, but that's okay. Sometimes we don't use motivational interviewing with patients. The safest option is always not to use substances. And there are websites that help give medically accurate, development appropriate information, of course. But motivational interviewing is a whole thing that I'm sure many of you have learned about. What we've learned in training folks to do motivational interviewing is it's much harder to learn how to do well than meets the eye. And almost every mental health center will do some kind of training on it, but very few folks will actually be really competent at the model. But it's a style of interaction that a pharmacotherapist, a psychotherapist, a family therapist, anybody could use. Personal trainers use it, right? It was used during COVID for vaccine hesitancy. So it's the state of the art in terms of motivational change. Miller and Rolnick have created some books for adolescents. I always make our med students that rotate with me read the books. You can learn a lot about it. This is one that I think is really good. But adolescents are particularly interested in autonomy, right? And so we really play on that very heavily with the motivational interviewing. And we're partnering with them. Adolescents with disruptive behavior disorders are used to people yelling at them and disapproving of what they're doing. So this is a real breath of fresh air for them when they're like, oh, you're gonna partner with me and you want me to help me achieve my goals. And so it works really well. And they're kind of shocked by the, how it feels. And so the hard part, I think, is the evocation. Like, that's where the therapists have to work pretty hard. So we could talk for hours about motivational interviewing, but we won't. You can do trainings. You get MINT certified. Those are like the official trainers in motivational interviewing. So of course we encounter a lot of resistance to wanting to change behavior, and that's okay. That's normal. Actually, if there's one thing you remember from this talk that I've learned in doing this work is most often when adolescents present with substance problems, they are not interested in treatment. And often what you see with family members is, well, Bobby, are you willing to go in and see these doctors? No, I don't want to go in. This is stupid. I use cannabis a little bit. It's no big deal. So what I've learned is it's okay that Bobby doesn't want to be here for treatment. He doesn't have to be. He doesn't have to have hit rock bottom. He can still come even though he doesn't want to, as long as you can physically get him in the door. That's what we're interested in, because we can use motivational interviewing with him. And so often treatment hinges upon whether caregivers think they can convince their kids to come. And I'm like, if you can, and there are kids that you cannot convince to physically come in the door, and that's a different story, right? That's a different intervention. But if you can get them here, I don't really care if they want to be here or not. That actually has no relationship with their outcomes. We can use motivational interviewing to work with them. And it's shocking how quickly they'll turn from like, maybe it would be better if I wasn't smoking weed so much. Like, okay. So anyway, so we use motivational interviewing to get there. So we assume that they don't want to be here. That's fine. We don't care. That's normal. We don't require that they want to be there. And that's where I think the public gets confused a lot also. Sustained talk is the, I love cannabis. I want to be a cannabis studies major in college, which is a major in certain places. And so, that's sustained talk. And so we're not going to argue with it, right? That's tempting for adults to do that, and doctors especially, but we're just rolling with it. So we're reflecting. That's interesting. Tell me more about that, right? So anyway, you guys have heard of motivational interviewing, I'm sure, but that's there is a adolescents, I think, is the take home. And then there's this really cool intervention called Family Checkup. It's not on this website anymore. NIDA took it down, I think, but you can get access to it. It's essentially just like a quiz that you give parents or caregivers, and it gives them like a personalized report of what their family needs to work on. And it might be like, you guys are great with communication. That's probably not really true very often, but you're great with encouraging, but boy, your negotiation skills need to be tuned up, or limit setting is really falling apart. So it gives them kind of a customized plan to work on. So the idea is, if you can't find a family therapist, or the family's not willing to work with a family therapist who could do this, you can at least give them some really tangible, practical tips. And maybe the pediatrician works with them, maybe a psychologist, whoever, but it gives them information really quickly that has been shown to reduce substance problems and improve substance outcomes. So the key, and you can imagine, good family therapies for substance use disorders include these 5 things, right? That's what they're focusing on. But this gives them a tailored plan. And so Family Checkup is the name of the intervention. It's been studied and used in a lot of different settings. Okay, so of course we will ideally want a high quality diagnostic evaluation. The case ads would be the gold standard. We're interested also in high risk sexual behaviors. A great program would be getting some baseline psychiatric symptom ratings and following them forward. Timeline follow back is the name for those of you that don't live in the addiction world of the assessment tool that we use. It's like a calendar where you fill in 3 joints on Tuesday, 5 bong hits on Thursday, and then you literally update it every time they come in. So you could say, oh, look, there's been a 37% decrease in cannabis use. That's a win, so it's very specific. So we do that. And then of course urine drug screens or breathalyzers are really an important part of drug treatment and monitoring. I guess one just little side comment, ASAM, American Society of Addiction Medicine, is a powerful organization that came up with a collection. They organized treatment levels in a way that state Medicaid plans really liked. And so you might say, I don't need to know about ASAM. Well, it depends on whether or not your state Medicaid plans have followed ASAM to guide their substance use disorder waiver programs. And so basically there's different levels of care, like 0.5 ASAM is a preventive model, and 3.0 is, I think, a partial hospitalization or residential, and they have these numbers. So if you don't live in the addiction world, you're like, what are people talking about with these ASAM numbers and levels? Why does that matter? Well, it's because state Medicaid plans tie their addiction treatment dollars to those levels. And so it's a very expensive book. I think it's like an $80 book, but like if you're going to get things through prior authorizations and stuff, you have to know your state probably expects you to understand ASAM. So it's just a big thing for people that do addiction treatment to understand that. So if you look at the research on what is effective for adolescents with substance use disorders, you find a ton of family therapies, right? So most of them are family therapies. So multidimensional, brief strategic, a whole bunch of things, multi-systemic therapy. And then there are also individual therapies, tend to be cognitive behavior therapy oriented, but combined with some sort of motivational interviewing. I'm just listing that there are 12-step models and groups. They are not the research literature is not very impressive for those models in adolescents. It is much stronger for adults. And there's also concern with, you might use the word contamination. Imagine a 14-year-old who's dabbling in cannabis in a group with a 17-year-old who's dealing methamphetamine and using cocaine, probably not great mixture there. So our program that I'll, tell you about, we actually don't do any groups at all. It's all individual. And so we tend to reserve group treatments for kids with more severe, more refractory. Like in a residential setting, it makes a ton of sense because everyone who's going to residential has pretty serious problems, right? So, but the default treatment I find in most mental health settings is throw a social worker in a group. How effective is that? Billing wise, great. So that's what's done in most community settings, which is potentially harmful. And then of course, medication management is an important thing. And you can see IOP, PHP levels of care. And what most people think treatment is rehab, right? And so you I think informed by MTV or other media, but actually very few adolescents would qualify in the ASAM, Medicaid matrix for that level of care. You would expect that they try adolescent or outpatient first. And it's been amazing with some of the projects we've done, how almost no one thinks about outpatient treatment and thinks that that could do anything or have any impact. And it's like, you should do that first and it probably will work. So that's interesting. And then the model we use is called Encompass. It actually comes from the University of Colorado, from Paula Riggs. And it innovates because it says, you know what, all these kids have mental health problems and addiction. Let's just treat them all together in one place. And it's okay if they have depression or, whatever else, ODD. And it's not a full course of treatment for all those things, but we're assuming they're together. And so that's fine. You don't have to have an addiction provider somewhere in a different building, a mental health provider. So and some of these websites have been taken down, but there are some guides that kind of describe these.
Taken down because of the whole.
Yeah, some of them were before that. NREP got taken down before that, but before the current administration. But yeah, it's been hard to keep track of which things are still active. So what does the evidence say? I just listed off all the options. So the best it's CBT models and family therapy models, specifically like the manualized versions. There are some other models that are, less effective. And then I think the main take home point is probably the least efficacy around just generalized drug counseling and 12-step for adolescents. Again, different for adults. Contingency management is something that I think a lot of people haven't heard of, but it's a very interesting modality for addiction treatment, right? So, for example, the VA embraces contingency management in a big way. So this came from the adult addiction space. And the idea here is it's just positive reinforcement. It's just like a behavior chart, essentially, that you would, child psychiatrists and psychologists are very comfortable with this. But the behaviors that are identified that you want to incentivize in contingency management protocols are showing up at your appointment, right? So attendance, not using drugs as evidenced by a drug screen, and completion of pro-social activities. This is the interesting part. So there's a lot of research that not surprisingly shows that when you're around people using substances, if everyone's smoking weed at your job, at the bagel store, just thinking of a local example, and you go to work, you're going to smoke weed every time. So maybe you shouldn't work at the bagel store anymore, So there's the ACRA model, adolescent community reinforcement approach, is basically like, how do we reorganize this person's life throughout treatment so they're not surrounded by drugs, they're not surrounded by people who use drugs, and they're but they're still having a really good time. They're still enjoying their life. So how do you do that? Well, each time they come into a therapy session, you have to basically give them a selection of a menu of choices of pro-social, meaning things that don't involve other drugs, that don't involve people using drugs, but that are supportive of you being abstinent, fun and social. And so that could be volunteering at the Humane Society or joining the marching band or going to a basketball game with some friends that don't use, whatever. So at each session, our kids are assigned three pro-social activities, and they choose them with their therapist, and then they come back, and if they've done them, they get prizes. So prizes, session attendance, negative drug screens, and pro-social activity completion. How does this work? It's like the wheel of fortune. So you come into your session, hey, you get all these things, you get a spin on the wheel because you attended your session. You get a spin on the wheel because you had a negative drug screen. And guess what? It was your first negative drug screen, bonus spins, and you've sustained abstinence, bonus, you've been absent for 5 weeks, 5 more spins. What happens when you spin? Gift cards, Amazon gift cards. So the wheel is like a whole bunch of good job, basically no gift card, quite a few, good job, small prize, $5. Smaller number of medium prize, $10, and then one $50 jumbo prize Amazon gift card. And of course, over time, you whatever prizes you want depend on at the time in society with your population, what do they like? So when we first started off, we were like, I don't know, trial size deodorants, the small prize, and the Colts donated some stuff, and that was a big prize. But now everyone just wants Amazon, and that has been the case for quite a while. So we're just go with Amazon. And so we have this cabinet full. So if it's a virtual visit, we figured out how to just digitally shoot over their Amazon gift card. Now in person, we just, either email them or give them the gift card. And, but it's this very well-established, pretty large effect size intervention for substance use disorders that you augment or do on its own. So if you did nothing else, you could still just do contingency management. It's very helpful for adults and youth. And it also models, like if you do good stuff, good, if you work hard, good things happen. If you follow the model and engage, good things happen. No one's yelling at you but you don't get a spin, so it's helpful. And some people have actually looked at how you can get, can you get parents to do their own contingency management thing and on their own at home? It turns out that's very hard to do, and that's some work from Dartmouth. Okay, so the model that I mentioned in Compass includes the cognitive behavior therapy, manualized treatment, individual sessions plus 3 family sessions. And then separately, the family has their own interventionists, their own therapists to work with them on effective parenting strategies. So that's different than those 3 sessions. You guys know, I'm sure what cognitive behavior therapy is. The thing that I've been impressed, so of course it has the functional analysis. That's really the core in week 3. But to get there, most of the kids come in like, I'm fine, drugs are not a problem, I use weed, it's okay, who cares? So you kind of break them down in a gentle way. Tell us about how happy you are. Let's go through the happiness scale. Tell us about your relationships with others. By the end of those sessions, it's like, yeah, I'm not very happy and my life isn't that great, which I know is a little demoralizing, but well, we're here for you. You're in the right place and drugs are a problem for you. It looks like, great, let's start working on this, and then the functional analysis is, what function is this substance serving for you? Is it helping you escape from reality because you have terrible PTSD, or does it make you look cool because you have autism and you don't know how to look cool otherwise, or, thousands of things. And then they work through the modules to deal with, the kids kind of buy in like, oh yeah, it's my depression that's driving this or whatever. Coping with cravings is almost always the first module, but the therapist selects from those modules. And then I mentioned the family therapy is super important. And it's in those 5 concepts we looked at on the other slide are really what they're focusing on. Here they are. Some of it's like a version of parent training, how to handle disruptive behaviors, but and you could go to town with these. You could have 1 million sessions. There's usually lots of work to do. What we find is it's very hard to get families to engage for very many of them. So we have a minimum of at least 3 sessions, and you do what you can. But there's a lot of folks who will not allow their kid into treatment if it means they have to do a lot of work themselves. And so we don't want to prevent those kids from coming in. And then for medication management, that's a part of the model as well. In addition to the contingency management and all these other things, we're addressing mental health comorbidities, which turns out to be hugely impactful in substance treatment if you treat one's depression or one's psychosis, right? But we also have, I think I have a slide, yeah. So we use a lot of buprenorphine, Suboxone products. We don't use methadone very often in adolescents in most states. I don't think that's even allowed. There's an interesting literature with methylphenidate, with methamphetamine treatment, and of course, nicotine replacement and actually there was just a varenicline trial that came out for vaping. It's like one of the first clinical trials for vaping. Only took like 7 years for the world to get one of those, but I personally am just a nicotine replacement fan for those kids. Naltrexone for either opioids or alcohol use disorder. We use a lot of naltrexone. It's amazing how many kids have very, very serious alcohol problems, like filling up their Nalgene water bottle with vodka before school. 7 uncles have died of alcoholism, like those kind of kids, like they really benefit. And in the case, adults, you would always use intramuscular naltrexone because they're in charge of their lives. With adolescents, you can get away with oral if you have a caregiver who can make sure they get it every day, which is so much easier sell for everybody than the shot. And just the concept, you'll hear this medication-assisted treatment doesn't just mean medications, it actually means a suite of behavioral interventions plus medicines, just to clarify. And for the caveats for the addiction research literature is it's way less robust than adults, of course, as with everything in youth. And but the outcomes are sometimes different than adults. It's not always the same thing. And we are less likely to need to use medications in adolescents than adults. Oh yeah, this is I don't know how much time, we probably don't have that much time to go through all these, but anyway, N-acetylcysteine was an exciting story for a while. Kevin Gray did really great work on that. It's been hard to replicate. So I still use it sometimes in certain kids. I think it does help. People have tried topiramate for cannabis use disorder I'm talking about. But for adults, the NAC has never panned out. So maybe from earlier cases that aren't as severe. Nicotine, of course, we have the nicotine replacements, probably the big thing. It's very hard to figure out for people who are vaping, what is the right dose of nicotine patch? So it's like stoichiometry from chemistry, remember, where you're like, okay, you're Mr. Fogg. That means it's how many milligrams of nicotine. Okay, how long do you use that thing? So it takes a lot of math to get there. Almost always, though, I end up with a pretty low dose of nicotine replacement, about 7 milligram patch. This is maybe controversial and off-label, but I do have them cut it. If they don't need 7, I don't want them 7. Pharmacists don't like that. I guess it's not approved. But and of course, with opioids, I mean, you can have a whole lecture. We can talk about buprenorphine and naltrexone. I think I have, some of these. So again, opioid intoxication, if you see it, like the pinpoint pupils are really telltale. Sedation, respiratory depression is what we really worry about, right? People look like they're nodding off. The opioid overdose folks, you can't wake them up. They're hypoxic, right? So their lips are blue, and their breathing rate is really slow, which is the problem. And so naloxone is the key. I don't know if in Minnesota you have a big naloxone advocacy, but there's everywhere. The idea is it's very safe. We should all have it with us, and it's no problem if you administer it at the wrong time. It's not going to hurt anyone. Big lifesaver with fentanyl, maybe multiple doses of naloxone, right, to bump that opioid off the receptor. But then it's time for withdrawal management and detoxification, or not. Maintenance, I should say. So in adolescents, you're usually looking at buprenorphine for the more severe users. Although I do make the case that naltrexone can be helpful for those that can handle it. I don't know if the problem with handling it is you got to go 7 to 10 days without using, and that's not an option for a lot of people. So that's the rate limiter there. And methadone, again, is really pretty much almost exclusively for adults. And you just see that the naltrexone has a really high binding affinity at the opioid receptor, and the opioid can't knock it off. So once it's on there, it blocks the feel-good cascade of chemicals. And you might say, why does it work for alcohol? That's an opioid receptor, but it's the endorphin system is affected by this. So it's a buzzkill. So that's what I always tell my patients. Sometimes we're also using antabuse plus naltrexone in those folks who can't get enough benefit from the naltrexone. I do that, and it helps. Okay, well, we won't go into all these in detail. You can have the slides, but so to summarize, we have historically models where mental health is in one place and addiction is in another place. And I think the idea is bringing them together it makes a lot of sense. And we found really, telehealth is a really good way to go. You could do the contingency management. We mail our drug screens to our families, and they just administer them at home. That can cause some conflict. You have to kind of work through that. And then one thing that we did that's similar to a child psychiatry access program, right? Remember that started in Massachusetts, ironically, the place with more per capita psychiatrists than anywhere else. They don't even have enough psychiatrists. So this was started where academic centers have these phone lines. I assume Minnesota has access for, maybe not. So CPAPs.
Like the kind of thing where you get
like you phone a child psychiatrist.
Yes.
Yeah. So this is that, except for just focused on addiction. So we started an addiction only hotline because it's just a different field, and you need different advice. And we're glad we did. We got some SAMHSA money to do this because the fentanyl epidemic kind of hit right around that time. And so typically these are emergency departments calling saying, okay, I've got this person here. Or sadly, the story is usually, I've taken my son to 7 emergency rooms every time he overdoses and no one has started buprenorphine once. And so, okay, thank you for calling. Let's start the buprenorphine in the ED now. We'll take over the maintenance of that tomorrow, is the story to kind of keep them alive. So this is a provider-to-provider helpline. It's the same concept of the child psychiatry access program. We actually also have an adult version of this. I don't know why adult psychiatry hasn't jumped on the train, because there's certainly plenty of adult patients out there who need help that primary care needs help with. But it's been a helpful model. Massachusetts also has a similar thing. But we will literally help guide you, or even just take over the care if there isn't enough care in a particular area, and it could be telehealth or it could be in person. But we have an experienced team that works with patients with substance use disorders. And then another thing, so this is the state of Indiana, and our health system has a very large footprint. These are our clinics. Red is, so red is our IU health facilities. And so what we have done is integrated interventionists, bachelor's level interventionists, bachelor of social work level interventionists, and there's also bachelor of psychology, clinical psychology folks who are certified as community health workers, and they can deliver brief interventions for a variety of things. Here, relevant would be the Teen Intervene model, which is a brief intervention for substance use, early substance use and prevention model by Ken Winters. And then they can refer for more complex needs to our, psychiatry program. And then we hope that we're trying to get the pediatricians to engage more in like nicotine replacement or naltrexone for alcohol use, maybe. Those will mainly come to us though. But when we first started the AAA line, we were really surprised by how unwilling the pediatricians were to engage in addiction treatment, but they were very willing to engage in mental health treatment. ADHD, depression, anxiety, they were very comfortable. And so we actually got a grant from NIDA to study that and how to spread the how to create like social networks that actually advocate like peer advocacy for addiction treatment. So we're working with the social scientists in IU Bloomington to help us with that. The other component for this addiction or this integrated care program is we have virtual groups. So like you try to find a DBT therapist that accepts Medicaid in rural Indiana, you will not find that. So we have like a DBT skills group and some other kind of specialized groups that are virtual. And so anybody from across our system can join and we bill for it. These are usually master's level folks delivering these or psychologists. The hope was just to fill the gaps in places where we knew we couldn't get care. So we have some executive functioning training and social skills training is actually our most popular group. That really surprised me. And it's not just kids with autism, it could be anything. And a variety of other issues, but those are pretty easy to run, pretty cost effective. The first model is the one that's what I'm referencing up there. It's comes from the John Weiss's group at Harvard. That is Match and First are two similar models that are like a unified protocol that train on skills for depression, anxiety, and disruptive behaviors in kids. So everybody gets that, but then some people also need a virtual group. So to summarize, I think we're getting close. Yeah. Just effective substance treatment should be really comprehensive. You need, interactions in the emergency department and primary care, and then specialty care that makes use of evidence-based interventions like cognitive behavior therapy, contingency management, medication management. Adults tend to need vocational services more often than not, but educational consultation can be really helpful. Peer recovery coaches in Indiana, at least Medicaid reimburses for those. I find it's very hard to find a steady workforce that can work with adolescents. That we feel comfortable with in the peer recovery space, but we're working on it. Monitoring throughout with, are you able to maintain sobriety? Let's use frequent drug screening. No one's, we're not accusing you. It's just how it goes. It's normalize that across your treatment program. They're just references. So, okay. Happy to discuss or take questions.
Any questions here? Let's wait and see if anyone posts in the chat questions.
I have a question for you. So again, wonderful presentation. I really appreciate everything you had to say. I see a lot of the same thing you're talking about with cannabis. People be like, oh, it's no big deal. It's everywhere now. It's even healthy. I'm a psychiatrist. I'm thinking about the kids who come in with a separate diagnosis who parents and oftentimes other people bring them in think it's the primary issue or the thing. They're like, I'm not worried about the cannabis because of their depression, because of their ADHD. And I'm glad they're getting some sort of treatment, but I'm wondering if you have any advice for like how to talk to a parent basically about like, yes, it's important that we treat their primary psychiatric issue or their secondary psychiatric issue, but the substance use is a problem that needs to be addressed in like a 30-minute follow-up visits,
Well, first of all, you want to have something you can refer them to. So it's a much easier conversation if you're like, oh, we got this thing we can just launch you right into. So if you have that thing, in terms of addiction therapy or whatever, I would make the argument that, look, we will absolutely treat your kid's depression, but I'm really worried here that we're not going to make much headway as long as the cannabis use is so severe. We know that, there's all kinds of research, whether it's anxiety disorders and, you're going to make less progress if you're an active cannabis user for any of these things. And that this, you know, I know that doesn't feel like the primary issue, but I think it's actually a primary driver potentially. And I would say you don't get you know, how often does that work? 50% of the time. I mean, I think a lot of people are often, I think, because they themselves use quite a bit of, a lot of parents use cannabis. Yeah, they're super defensive around that because they're doing something, they don't want to hear about it. And so it's, you know, that's, you sort of wait for more consequences to emerge, I think, in those kids. You keep talking about it, you keep planting the seed, but you know, sometimes with like ADHD, people, I think it's fair to say, look, this is a controlled substance. I don't think many physicians feel really comfortable prescribing this while you have an active drug use going on. I really need you engaged in this program as well. It's a little bit harder with the non-controlled substance, I guess, to make that case, but really to helping educate them on the, you know, the effects. But the key is, you know, getting them there. But it is, especially if they use themselves, a hard sell pretty often. Yeah, that's one thing I've learned from the primary care work. I'm used to, like, people who present in crisis to emergency departments are very motivated for treatment often, right? People who are in primary care who are just carrying on in life and we give them a screener and it lit up with problems, they don't care as much about getting treatment. So they're much less motivated. So I've allowed myself to know in my career that I'm gonna help the people that want my help, and there's a lot of folks who don't, and it is hard, but yeah, you try.
I have a question about, you know, sort of you took it from different silos, right? About how traditionally, like, substance use treatment has been separated from mental health treatment. And at least my experience with it is it's more on the substance use treatment side where they're not,
Yeah.
they think that their interventions work well. How do we bridge the gap? How do we get, like, the substance use treatment community to
Yeah.
recognize that we need
Yeah.
to integrate?
Well, one thing that's a really interesting development, we don't have a lot of good news sometimes, it feels like federally right now, but SAMHSA distributes money to states in the form of block grants, mental health block grant, substance use block grant. I think for the first time they're distributing a block grant that doesn't force states to separately award funds. Like, if you're an addiction provider, you get these funds, and you know, and so that's interesting. I mean, just as an aside, there's like structural reasons why this is the case. And Medicaid programs are separate and all of that. But yeah, how do you, I will say, the addiction treatment community is a very different community than mental health community, and sort of bridging them. Like what we've found is I'd rather hire a mental health therapist who doesn't know anything about addiction and train them to learn about addiction, and because they're willing to sort of work in this community. So, I mean, I don't know how to fix the whole problem, but in our setting, it's just, we're going to build these things together, and we're not even going to allow them to be separately siloed. And I'm not disparaging, like, within a Department of Psychiatry of addiction psychiatrists, and like they get it, you know, but like there are these freestanding facilities, right, that are run by a lot of, you know, social workers and nurse practitioners. A lot of private equity is very big in the substance use treatment space. If you look at you know, people have figured out this is a very profitable industry if you run it a certain way. It doesn't include a lot of psychiatrists and psychologists and, you know, their way, but so they're not, they want to do it that way, but states create a lot of that. I mean, like, for example, if I set up a mental health clinic, I don't have to have it be certified by the state, but I do if it's an addiction treatment facility, and it's a whole, you know, separate set of rules. So it is hard to combat that, but yeah, it's not an easy solution. Yeah.